I'm Laura Magson. I'm a solicitor at Boys Turner. Welcome to you all and many thanks for listening in today. I'm joined by Samantha Westbrook. When we started organising our annual study day last year, I approached a number of speakers, including Samantha, who kindly agreed to talk about 8 months ago now at our mesothelioma and lung cancer study day. I don't think anybody expected that that study day wouldn't be able to go ahead face to face in our offices as planned, but nevertheless we've had to adapt. Samantha has kindly agreed to do a short webinar instead. For those that don't know, Samantha Westbrook is a peritoneal clinical nurse specialist at the Peritoneal Malignancy Institute at Basingstoke Hospital. Her post has been funded by Mesothelioma UK since I think September 2018. It's a charity that's fantastic. It's nationwide and dedicated to mesothelioma patients. Thank you, Sam, for carrying on in these unprecedented times. I'll hand over to you now, Samantha, if you'd like to tell everybody what you're going to talk about today.
Oh, hi, good morning. Hi, Laura. Thank you for the kind introduction. So this morning I'm going to talk to you about peritoneal mesothelioma. I'm going to give you a little bit of an overview of the peritoneal mesothelioma. We're going to look at the current landscape for what that looks like in the UK for patients with peritoneal mesothelioma. And then I'm going to touch on what the future might hold and looking ahead a little bit more. So I'm going to share my presentation with you. So these are the numbers that have been recently published by the mesothelioma audit. If we look at the statistics here, there are about just over 7,000 patients in the UK diagnosed with mesothelioma in the 2-year period. This is 2016 to 18. Of those, about 260 cases are peritoneal mesothelioma. And we can see here that the median age is around 71. There are more males than females, but there are slightly more females than males within the peritoneal cases. This audit really showed the great work that's being done by the charities, by all the hospitals with the national MDTs and all the regional MDTs. And in particular for us, it showed that there was a doubling of referrals to our national peritoneal mesothelioma MDT from the previous 2 years. So that's a great achievement for patients who are seeking that expert advice. So let's have a look at what peritoneal mesothelioma is. It's the lining of the abdomen is the peritoneum, and what happens is the peritoneum thickens when mesothelioma is present, and during that thickening it causes fluid to collect. Now this fluid is called ascites, and when that happens the abdomen swells. The patient can be quite uncomfortable with all that fluid there. There are two linings. There's the lining that's the visceral lining, which is next to the abdominal organs, and there's the parietal lining that lines the abdominal wall. Now, peritoneal mesothelioma spreads outwards and around. It doesn't spread within, it doesn't infiltrate, and it isn't hematological spread either. It's quite unusual to see the lymph glands affected by it and to see any metastases out of the abdominal cavity. It's very rare and it's very uncommon. At the moment, we don't know of any cure, and there are some thoughts on how mesothelioma gets to the peritoneum. And one thought is that the crystals are ingested and slowly over time they migrate from the lumen of the GI tract to the peritoneum. And the latency period is slightly shorter than that of the pleural mesothelioma, and that's been documented around 20 years. There are some documented cases of non-asbestos causes of peritoneal mesothelioma. Some say that radiation causes it, so that's the directly irradiated tissues. There's instances of recurrent peritonitis, so patients who have relapsing diverticulitis or patients with Crohn's disease, genetic dispositions, and also a virus called simian virus 40. So if we look at peritoneal mesothelioma, it's actually classified into some different subtypes. We can put a couple into the low-grade spectrum, and we can put some into what we call the higher grade, the malignant spectrum. In the low grade, we see something called multicystic mesothelioma and well-differentiated papillary mesothelioma. And in the high-grade malignant spectrum, we see our epithelioid and our sarcomatoid and our biphasics. And the distribution and the sites of disease can vary between each patient. So the multicystic is a low-grade borderline malignant tumour. It rarely spreads outside the abdomen, and it does have high rates of recurrence locally. The well-differentiated papillary is even rarer. We don't see many of those patients with this, and it's slightly more frequent in the peritoneum than in the pleural. Our most common is the epithelioid, and slightly more rare is the sarcomatoid and the biphasic. So patients often have a delayed diagnosis, and this is due to the symptoms being fairly non-specific symptoms, rather common symptoms that you could put down to perhaps more common issues. So we have things like abdominal pains, we have abdominal swellings, change in bowel habits, fatigue and weight loss. Perhaps a patient has had a hernia and loss of appetite. So quite sort of non-specific, some red flags there for cancer symptoms, and patients often go down different diagnostic pathways before they get to this diagnosis. And sadly, the patients do present at an advanced tumour stage. So how do we diagnose it? Well, often patients would have had a CT scan. And for us, when we're looking at a CT scan, it's extremely important to look at the small bowel using this CT. And we want to almost estimate the degree of disease on the small bowel. And that can tell us what surgical options are available. PET and CT scans yet show a superiority over the CT scans. Diagnostic laparoscopies are something that we use to look at the disease distribution and estimate the volume of disease and take biopsies. You can aspirate the ascites, so that fluid in the abdominal cavity we were talking about earlier, and that can be helpful, but often it's non-diagnostic to give us a diagnosis of peritoneal mesothelioma. There are options of treatment pathways. Some patients go onto a surveillance program where we watch the disease. They have scans, serial interval scans over a period of time, just watching the disease. Some patients opt to have a chemotherapy, and some perhaps would consider having a surgery. There are clinical trial options available as well for patients who perhaps are not suitable for surgery or have had a couple of lines of chemotherapies. So we just have a quick look at the history. NHS England in 2015 made the decision not to routinely commission surgery for peritoneal mesothelioma. And the surgery that we do at Basingstoke is called cytoreductive surgery and hyperthermic chemotherapy. We shorten that to CRS and HIPEC because it's a bit of a mouthful to say all the time. And the standard treatment is the chemotherapy. Now, we have a special interest in peritoneal mesothelioma at Basingstoke and Meso UK in particular as well. And in March 2016, the team decided to set up a national peritoneal mesothelioma MDT meeting. And essentially they wanted to look at and gain a consensus on what treatment advice they can give, and to look at trends and how patients do over time, collecting that evidence and looking at the data. And the decision was made to continue offering the surgery for peritoneal mesothelioma at our hospital. So the MDT looks a bit like this. It's a virtual MDT, a bit like what we're all used to at the moment. We have the peritoneal malignancy surgeons at Good Hope in Birmingham dial in, and the Mater in Dublin dial in as well. We have an expert pathologist who is well known in looking at peritoneal mesothelioma. We have specialist nurse, we have our radiologist, we have an oncologist, and our MDT coordinator collates all the information for the meeting. And we review all the histology, so we ask for all the tissue blocks and the biopsies to be sent to us for our pathologist to have a look and to give a second opinion. All the images are reviewed. We look at the clinical information. We might have DVDs of laparoscopies that have been done in the local hospitals, or pictures for us to look at. I myself may have spoken to the patient's specialist nurse in their local hospital, or I might have actually spoken to the patients or the families themselves, acting on their behalf and knowing their wishes. We recommend a treatment pathway. That may be seeing an oncologist, or it may be looking at are there any clinical trials available, or it may be looking at assessing them for the suitability for the surgery. So just popped in a table here. We recently published a paper of our MDT, and it's interesting to have a look at the number of cases that we looked at. The majority, as we know, the most common, epithelioid mesothelioma, followed by the multicystic, and then the biphasics after that. And what we found from the data was that patients who received the CRS and HIPEC surgery showed a better 1, 2 and 3 year overall survival. And those were in patients that were carefully selected through this MDT process. So what does the surgery involve? Well, completely removing all this tumour, we call it complete cytoreduction. And it's aimed to remove all of that macroscopic tumour, but it can come with its complications, such as hemorrhages or fistulas, perforations, the wound not healing, or abscesses. And at times we can offer operations to remove a bulk of disease, perhaps if that's causing problems for a patient, discomfort, pain. So we can help to remove disease that's causing symptoms there. So in the sugar baker technique, this is all the procedures that are involved. Now, not every patient will have all of these procedures. It's specific to where their disease is. So right sides of the bowel can be removed. We would remove something called the omentum, which is a fat apron that lays over the top of all of the abdominal organs. And spleen may be removed, the gallbladder may be removed. Patients may need a hysterectomy, or their ovaries removed. We would strip the peritoneum and strip the linings of the diaphragm, and perhaps the surfaces of the liver, and in some cases there are areas down in the rectum that need to be resected. Now, the HIPEC is the heated chemotherapy liquid. So this addresses all the disease that we perhaps can't see, the macroscopic disease. So we've removed all of the disease that we can see with the CRS, and then we're addressing the macroscopic disease, which is the chemotherapy wash. Now, this is isolated to the peritoneal cavity. It's pumped in. I'll show you the machine on the next slide. It's left in the cavity for about 60 minutes, heated, and the organs are bathed. There's no toxicity or side effects to the patient, possible tiredness or nausea, but you would expect that after an operation anyway. So this is what it looks like. It's a metal sort of scaffolding that's built around, and then the tubes via the machine are pumping the hot chemotherapy wash in, and then the organs are bathed, and then it's removed. For a patient who's undergoing this surgery, this is sort of what their initial journey might look like. On the day of admission, they'll come to us 2 days before the actual operation itself, and all the usual paperworks are completed. They're given a liquid for bowel to clear out the bowel. It's called Picolax, which is a bowel prep, and they will be having clear fluids only. And the day before the operation is one of the busier days, actually. So most of the team will come and see the patient and talk to them. We have a dedicated stoma team who come and see the patients. So that's for patients who perhaps are having part of their bowel removed and need to have a bag on the outside on their tummy for the stool to come out of. That could be either permanent or temporary. The anaesthetist, so the person who's putting the patient to sleep and giving all the sedation, will come and see them. We have a team of dietitians. They will talk about the artificial feeding that they'll be getting for the first 10 days and then how they reintroduce food. We have physiotherapists and exercise specialists, and they will see the patient really from the beginning after the surgery to get them up and moving. We offer them a visit to the intensive care unit where they will stay the first 24 hours minimum after their operation. And the nurse, so myself, I'll see the patient as well, and we talk through all the ins and outs and what it might look like after the operation and all the drains and the drips that they will have. And on the day of the operation, so they don't have anything else to eat and drink from midnight the night before, and they get woken up about 6 o'clock and start getting ready. A relative's welcome to come and take them to the operating theatre, and the relatives will receive 2 phone calls from the surgeon during the day, one usually just after lunch and then one at the end. Well, these patients do have complex care needs after this operation. Often they would have chest drains if they've had those diaphragms stripped, as I had mentioned earlier. They have multiple abdominal drains to drain out any fluid collections. They'd have to learn about the stoma care if indeed they have a stoma. Not all patients do. Pain relief is one of our big focuses, so we really don't want the patient to be in any pain. They'll have an epidural in place and a button that they can press to deliver extra painkillers if they need it. They are artificially fed for around 10 days. And like I said, we get the patients up and moving very early on. Sometimes patients will have the chemotherapy wash after the operation as well. And that's what we shorten to something called EPIC. It's not always done, but it can be inserted through one of those drains and left in for 24 hours and then drained out the next day. Now, for a lot of patients, this is an emotional time, and we recognise that. And so we do offer psychological support. We have a psychologist team for our patients, and they're screened before for any anxiety and depression, so that we're able to support them the best we can during this process. There are various ways for us to get to know our patients, and this is something called filling out a form called This Is Me, and we can learn a little bit more about the patient before they come and stay with us. We offer inpatient diaries as well. So there are a lot of worries and concerns for these patients, and I think at the top of the list for many, and which isn't unsurprising, is the prognosis. And what does this mean? Can we remove all of their tumour? Have we got it all out? How much longer will they live for? And so we have to support those patients and try and answer those questions as best we can. The stoma can be something that nobody particularly wants, and so we offer some counselling for that. The scar is, as you can see from the picture, is a big scar, and for a lot of people that's quite unsightly, and it can take some time to look at, and their belly button gets removed during that process as well, which is quite unusual to when you look down and see there's no belly button. So the scar can be a focus for a lot of patients. They're with us for about 3 weeks. And then afterwards, when they go home, we offer a follow-up care. So we do telephone calls at certain points to check that the patients are recovering well at home, and liaise with their local teams. So my role, probably this list isn't exhaustive. I support the patients often remotely, not only those that are having this surgery, but those are going through all different treatments in the UK. I would signpost them to various teams or various services, help them with any symptoms that they are struggling with, seeing if there are ways that we can help to manage those, speaking with their specialist teams in their local hospitals and their specialist nurses. And often it can be talking about the disease itself. As we said, that it's a very rare disease, and they find that they want to talk to people who have experience in this. Service development, so we look at how we can improve our treatments that we're offering, how can we get it known what we're doing at Basingstoke. So I just thought I'd run through a quick case study with you here, just to sort of set a bit more of a picture of perhaps what it might look like for a patient. This referral came in last summer, a young female with fit and well and no medical history. And she had those non-specific symptoms that we spoke about, and was put down as something called irritable bowel syndrome. But these didn't resolve, and so she was referred into the hospital. And she had a laparoscopy, so this was something to explore what might be going on. And inside, the pelvic area looked abnormal, and so there was a biopsy that was taken. And this unfortunately came back inconclusive, and so no diagnosis could be given. So she went through a second biopsy, and that was reported as the well-differentiated papillary peritoneal mesothelioma. And that was the one that we spoke about that sits in the low-grade spectrum. And she was informed by her local team that this was something that was low-grade and indolent, and was informed that her treatment options could vary, and it could be either the watch and wait, or perhaps there might be some chemotherapy or an operation might be needed. So her local team referred her to us at our national MDT, and we had a look at that in August. And our pathologist had a look and subtyped it as epithelioid, so that moved it over into the malignant spectrum. And we do a particular test called a Ki-67, which is slightly a prognostic indicator, and hers was around 20%. Around 9% is normal, so moving up higher is slightly more aggressive. We had a look at her scans, which showed quite extensive disease in the lower part, so in the pelvis and the peritoneal linings, and also on the diaphragm linings. We suggested that she should consider some fertility options. And we had a look at the DVD from the laparoscopy that was done in her local hospital, and it was quite difficult for us to have a look to see the small bowel and to see if there was any disease there. So we decided we'd offer her an outpatient's appointment, and we would do a laparoscopy here at Basingstoke to assess the disease. So we did that in October, and it was decided that her disease was operable, and we'd be able to achieve that full cytoreduction and that no bowel resections would be needed. And she'd, in the meantime, seen a fertility team and had successful egg collection. So in November, she had her operation. She had the CRS and HIPEC treatment. As you can see there was disease in quite a lot of areas. We removed her peritoneal linings on the left and the right, and the omentum, which was that fat apron. We removed her spleen. She had a cholecystectomy. We removed the linings of both of her diaphragms on the left and the right. We removed the linings in her pelvis. She had a total hysterectomy and removal of her ovaries. And we did we removed her appendix. And she had a bladder repair as well, and there was a slight tear there. And then she had the hot chemotherapy wash for an hour afterwards. And she had, when she came out of the operation, she had 4 abdominal drains, a right chest drain, another drain. So she was in the operation for about 7.5 hours with a minimal blood loss. She recovered really well after the operation, and after 3 weeks, she was discharged to her local team for monitoring regularly, and we recommend annual scans. So that was a really good outcome for that patient. Referred to the national MDT, where we looked, and she was suitable for surgery, and her outcome was successful after the operation. So if we have a look into the future and what's ahead of us, well, we want to continue our MDT, and we will continue that, developing it, looking at the patients that have been referred over the time, and how they are doing, what treatments they've received, to get an idea on how these patients are being treated and which ones are being treated in which part of that spectrum, in the low grade and the high grade. We aim to go back to NHS England with our data, and data that's been published worldwide about the CRS and HIPEC surgery, and ask for them to commission the surgery. We're looking at offering a prehabilitation service for the surgical patients, so helping them to get fit and be in best shape as possible for recovery afterwards. We are looking at the clinical trials that are available with the systemic treatments that can be given for these patients, and immunotherapy is something that's at the forefront at the moment. We're looking at something called PIPEC, which is a pressurized chemotherapy that's done at laparoscopy, that's almost sort of sprayed into the abdominal cavity. And that's something that we're looking at the moment, and watching the data worldwide, and thinking about whether we can offer something in a clinical trial setting. We need to develop more information for patients, in particular sort of leaflets and online information. And I think one of the big things that these patients and their families are asking for is support for one another. And we are looking at ways at doing virtual support groups and events that we can do to help them talk to each other and share their stories. So in summary, if we have a look at what we've just spoken about, peritoneal mesothelioma is extremely rare, and it has links with asbestos exposure. And the chemotherapy is a good treatment option, which does give a limited benefit. It's a palliative treatment. And from what we've seen in the work that we're doing, we can achieve some good surgical outcomes for those patients that have been carefully selected by the MDT. Thank you.
A really helpful insight into peritoneal mesothelioma. I think what you said about just providing the support to all the patients, but also pre and post operation, I think that will be really reassuring for some of the patients listening to your presentation. And it's also just kind of dawned on me about the remote MDTs that you and the team have? Because obviously I'm assuming those MDTs go ahead because of geography, or have done in the past, because you've got specialists from all over the country, you've got treating patients, not necessarily in your local area. And I think we've shown, haven't we, that those support group meetings as well can go ahead remotely. So I think that's, it's a really positive step that, you can hopefully start to offer that remote support group as well.
Yes, yeah, absolutely. So I think we're going to start our first virtual support group on the 3rd of July, which is the Action Mesothelioma Day. This year's being done virtually and hosted by the UK Mesothelioma Alliance. And I'm going to run a similar Zoom call in the morning for patients or their families if they want to dial in, and we can have a chat with other people around the UK. And then that will launch into the event that's being held by the Alliance.
Brilliant, fantastic. So I've got one question just about the statistics that you mentioned right at the beginning. And of course, we see more males with mesothelioma, but what I was particularly interested in really is with the females, the incidence for peritoneal mesothelioma is that little bit higher than for pleural. And is there any reason behind that? Do we know?
So I think we could probably have a look at those non-asbestos causes in a bit more detail, and perhaps those will mean that female patients perhaps are predisposed more. The lower grade mesotheliomas, so the multicystics, they seem to be more prevalent in females as well, and there could be some hormonal link there.
Okay. And now final question is from one of the attendees. So it's quite a specific question that you may not be able to answer exactly, but he is at Basingstoke Hospital and he wants to know really if his CT scan is due to go ahead in August. But obviously we're in a bit of uncharted territory at the moment. What's the feeling on whether or not a CT scan's happening as normal? Will it be postponed? What do you think might happen?
Yep, so services are still running. There are some slight delays, but I think we're seeing, particularly today, services in the retail industry are all up and running today. And I think we'll see a quick escalation of services resuming. So not to be too panicked about an August scan, and just to reassure patients that we will get through their routine scans as quick as we can.
Great, that's really helpful. Thank you, Samantha, and thank you for sharing your time with us and taking the time out today. Many thanks.
Thanks for having me.